Let's welcome Professor Tibor Kovacs.
First of all, I would like to thank Tencent to invite me to this great event. It is a great honor to be here and to share with you my thoughts about perspectives on the future of the cancer surgeon. I myself, I'm a cancer surgeon. I work in breast cancer surgery and reconstructive surgery, and I also lead an organization who is focusing on education and training of cancer surgeons. Last year at a meeting at the so-called ECHO Summit, European Cancer Organization, where we discussed the future of steps from science to real-life oncology, what we've realized together with our patients representatives present at the meeting is that inefficiency is an aspect of cancer care that is not focusing on what matters to patients. So any money spent on cancer care which is not improving outcomes, it is something which is a wasted money. On this slide, you can see on the right side the Old Guys Hospital where I am working. This is a 400-year-old hospital, and on the left image you can see the current new environment of the hospital, where you can see still the hospital in the right lower corner, but the new buildings around. And the idea from this is that we have to build on past and tradition. Nowadays, medicine and healthcare is changing. Education and training in cancer surgery is rapidly transforming. If somebody would like to become a cancer surgeon, or a surgeon in general, they have a very long pathway in their training with complex, comprehensive knowledge required. And you can see different phases how a cancer surgeon has to be trained, from medical school, then passing towards the general surgical residency training, advanced training in surgical oncology, and you have to certify then to become an acknowledged breast cancer or cancer surgeon in general. Later on, you can still have to maintain your certification. There is lots of study and learning on this long pathway. Across the world, there is a significant variation in training length according to the HDI index. This index is called Human Development Index and is a combination of a statistical composite of life expectancy, education, and also per capita income. In the left upper corner of the slide, you can see those countries who they have higher HDI indexes. These are the dark green and light green colored countries. These countries spend more money and their HDI on education and training, and also their per capita income is higher. Therefore, their HDI index is higher. Therefore, also the time spent on education and training of cancer surgeons is much longer. The right upper corner shows the Southeast Asian countries. The length of training of a cancer surgeon varies between 10 and 15, 16 years. The European Society of Surgical Oncology worked on a project about 10 years ago, and what we wanted to see is why do we need a so-called core curriculum in surgical oncology in Europe? What is that knowledge, theoretical and practical knowledge, what a surgeon would need in order to become a certified cancer surgeon? There is also a need for standardizing this treatment in cancer surgery. As you've seen on the previous slide, there is a huge variation in the length of the training and the types of the training too. A few years later, we recommended a so-called core curriculum for a specialist training in surgical oncology within Europe, and this core curriculum was later on expanded, and together with our colleagues from the Society of Surgical Oncology of US, we created a so-called global curriculum in surgical oncology, which overarches mainly across the world, and it recommends what competencies are needed during surgical training. And these competencies are related not only to practical and theoretical knowledge of surgery and other disciplines, but you also need communication skills, you need confidence, you need judgment, and you also need experience. So there is a time-consuming, lengthy training to become a cancer surgeon. Besides the length of the training, you also need quality of training. So certain centers are suitable for training, not all of them. You also need skilled trainers, and you have to train the trainers in order to become those people who they will train the next generation of cancer surgeons. And your knowledge will have to be assessed, and you have to undergo different examinations to become a certified cancer surgeon. We also thought about a certain so-called minimum set of standards for research literacy to improve outcomes. It is known that those countries who they spend more money on research and cancer research, they have better outcomes, they have better survival rates. Therefore, a global curriculum in research literacy was created, again together with larger surgical oncology societies. And what we've seen is that there is an inverse relationship between the level of research activity and cancer-specific mortality. So mortality is lower in those countries where the research activity and publication is higher. These are the countries who they have the highest rates of published literature and submitted manuscripts, and their cancer-specific mortality is also lower accordingly. This is evidence-based. This is a very interesting data which relates also to China. These are data from the European Journal of Surgical Oncology, which is the second largest cancer surgical journal in the world. And you can see on the left-hand slide the top 10 countries by submitted manuscripts for publication. And on the left side, the middle row shows those 10 countries who they have accepted manuscripts. China is on the first top place for submission of manuscripts. For this journal, they've submitted more than 400 manuscripts. The acceptance rate is about 10%. If you compare this with other countries who they have slightly lower submission rates, this is a relatively low rate. So there is need for some improvement and education of surgical oncologist colleagues in order to have their manuscript accepted in major international journals. On the right-hand side of the slide, you can see the so-called science direct usage. China is the second largest country who uses and downloads articles from this journal, following the US. So that's also very important data in what regards how Chinese doctors and surgeons are using the internationally published literature. The European Society of Surgical Oncology created a so-called action plan to promote high-quality research based on the previously mentioned data. And we have a strategy plan for clinical research, paving the way for the culture of research in cancer surgery. Usually surgeons are not very keen in doing high-quality research activities, so that's what we have to promote in order to make sure that our cancer surgeons, future cancer surgeons, are properly trained in research of different treatment methods. So this action plan has 4 pillars. We would empower young surgeons and master research methodology. This is very important. We would expand collaboration between different international societies and also specialties and communities. And we would encourage surgeons to be involved in translational research networks. And of course, we have to advocate for better funding for cancer-related research. I would like to talk to you in the next few slides about a study commissioned by the Royal College of Surgeons of England back in 2017. And this study shows us that in the future 2 decades, most likely that patients will enjoy less invasive surgical techniques and even better outcomes. Less invasive and more personalized treatment. The role of the surgeon will undergo a revolutionary change, and data analysts, bioengineers, IT technicians will become somehow part of the surgical team as the technologies become more sophisticated. All in one, nowadays and in the future decades, what really matters is who has the right skills to treat a patient, not whose right it is to provide that treatment. So surgery will be transformed over the next 2 decades, and transformation of surgery is also going to transform how the clinical services are delivered. And there are 4 aspects of delivery of cancer care which is going to change, and what is going to be affected in the future is which technologies will make the greatest impact in the future. What does the future mean for patients? How will the delivery of surgery change in the future? And what is the future of the surgical team? If we take them all, one by one, technologies with greatest impact in the future will be the minimally invasive approaches in surgery, such as laparoscopic and more robotic surgery, with less invasive diagnostic and treatment opportunities. Imaging, virtual reality, and artificial reality will have a significant impact and will give a better guidance during surgical procedure planning. Artificial and virtual reality can be used also for training, and surgical procedures can be rehearsed before they are done. And all this will lead for a better standardization of the procedures and also of the training. Big data, research, and genomics will create and will lead to better prediction of disease outcomes, a more personalized treatment. Genomic profiling will help developing personalized medicine, and the choice of treatment based on their predicted success for each individual patient. What will the future bring for the patients? Well, a lower risk to harm, more predictable outcomes, and faster recovery. And the general surgery gradually will become less invasive and more precise, and potentially surgery will focus more on preventing illnesses and not just to treat them. Surgery is likely to increasingly focus on improving quality of life and operating on people with the aim of prevention. So not only surgery for advanced disease, but also to prevent cancer, and preventive operations are more and more popular in different organs and different types of cancers. There is also a change expected how surgery is going to be delivered in the future, how the future operating theater is going to change. The role of digital technologies, artificial intelligence, enhanced anatomical imaging will guide the surgeon to perform their procedures. Complex operations, complex cancer surgery has a tendency towards more centralized care in so-called multidisciplinary hubs, where all specialties are available in one center, and the results and outcomes on the long term are far better if you centralize high-quality care. It is also cost-efficient. Telemedicine and digital platforms, and such as virtual clinics, will be a part of our daily life for preoperative and also for follow-up assessments. We base more and more of our activity on IT-based medicine. Currently, we still use our so-called model-based training facilities to teach surgeons how to operate. And this is one of the SO courses where we teach breast cancer surgeons how to perform certain techniques, procedures. These courses are very popular, are hands-on teaching facilities, but perhaps this is also going to be the past if further developments in technology will happen. Novel techniques in breast cancer surgery is taking place. In the last 2 years, we've seen lots of developments. Although robotic surgery is used for more than 10 years for different other organs, such as kidney surgery or other types of surgery, it was less used for breast cancer surgery. It seems that robotics will take place partially, most likely, the place of traditional breast cancer surgery. You can see from these slides and graphs that the learning curve for these procedures is relatively short. After 10-15 procedures, you can halve the operating time, which was very long at the beginning, but it becomes reasonably long. And this is what we have to focus on. On the left-hand side of the slide, you can see the procedure itself, how a breast gland can be removed by keyhole surgery, by robotic surgery, with very good results and very quick recovery for patients. Now there is a question, how can the clinician of nowadays and the surgeon of nowadays fit onto the new stage of changing healthcare? Our training was more traditional, And how are we going to adapt to the new situation where technology is going to take over part of our work, or even more than that? You can see on the right-hand slide that there is a significant increase in the last few years, an exponential increase of publication in artificial intelligence, for example, in radiology, especially in MRI and CT scanning. The amount of publications increased from 100 per year to 700 per year in the last 10 years. So artificial intelligence, machine learning, and deep learning is taking place, and it's taking the place of lots of radiologists. So the question is whether this is a threat or an opportunity for clinicians. Radiologists can have, and also surgeons who they use artificial intelligence more and more often, can have a leading role in introducing these technologies in healthcare, and they will probably do further reduction of certain types of their work, but more a leadership aspect. Changes in how pathology reports and pathology reporting is delivered. With a modern pathology report, where there is lots of focus also on genetics and genomics, a specific cancer, we do not just have a so-called mugshot, but we also have the killer DNA identified. This will lead to precision medicine, which is going to be able to determine the optimal treatment for individual cancers and also for individual patients. Targeted therapies, it is going to be some kind of a road toward better cancer treatment and improved outcomes. And most likely, surgery is going to be far less than it is nowadays. It is going to be far extensive, far aggressive, but sometimes you have to consider that less is more and simpler is better. This is probably the future of cancer surgery. What I still want to mention to you is that surgery is delivered by humans, and there is a human factor in cancer surgery which you always have to consider. Nurses, cancer surgeons are working together for performance, and there are certain stress levels which are related to our performance, and you have to also think about the negative impact of the stress on the staff and colleagues who they work on cancer surgery. So a certain lower level of stress, it is useful. You have an optimum level of stress, which will lead to an increase of performance. Later on, the higher level of stress can lead to exhaustion, anxiety, and breakdown at the end. So what we've done, we've assessed also the quality of life of surgical oncology residents, young surgeons across Europe. And what this survey showed is that about 44% of the surveyed colleagues showed an abnormal sleepiness score. There was a positive screening for depression in about half of these colleagues, and a burnout in 25%. One of the major causes mentioned by them was lack of mentorship, lack of leadership in training and education in cancer surgery. If you want to have a look into the major general causes for the physicians or cancer surgeons' burnout, this publication in the Physician Lifestyle Report back in 2015 showed the first three most often mentioned causes are too many bureaucratic tasks, spending too many hours at work, and increasing computerization in practice. So again, the question is whether technology is helpful or it is a cause of physician burnout. This article was recently published in May 2019, discussing whether artificial intelligence can offer hope, whether artificial intelligence can bring a solution to these psychological problems, what I just mentioned to you. And it seems to be that technology advancement can lead to improvements. Artificial intelligence can be used for data management, the day-to-day operations such as the dictation, scheduling, clinician-friendly patient record systems. Also, artificial intelligence can have a role in decision-making, decision support, to decide about different treatment options, algorithmic decisions in the multidisciplinary management of cancer patients. And artificial intelligence, at the end, it can have a major role in diagnosis and treatment of cancer patients. ESSO tries to adapt to the changing environment, and we would like to train our cancer surgeons, our residents, to offer them as much support as possible in what regards supporting research activities, also interactive educational projects and programs, annual congresses where different topics are discussed in details and colleagues updated. And we also have a communication system with our patients to receive their feedback, what patients need, and they always tell us that they need those plans which are leading to better outcomes. I would like to close with the words and with a short study presented by Professor Umberto Veronesi, who was the leader of the Milano Cancer Institute, one of the largest cancer institutions from Europe. He published a short article about grand challenges in surgical oncology. This goes back to 2012. And what his view was, and I would fully agree with that, is that cancer surgery nowadays is focusing more on preservation of anatomy, functionality, and improvement of quality of life. The surgeon should not only act as a technician, but as a real scientist, being able to understand the results of basic and clinical research beyond the surgical domain. So surgery and cancer surgery in general has transformed from maximal tolerable to minimal effective treatment. Thank you for your attention.